evening, ladies and gentlemen, colleagues. On behalf of the members of Organizing Committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, Europe, especially England, India, and all countries across the globe to this webinar. This webinar is entitled Allergies in Children. We have an eminent speaker, Professor Nick MAKWANA from UK. In a short while, I'll be introducing him. We are also having eminent panelist, Dr. Mahesh Katre, who is also a pediatric allergist, and our moderators, Dr. Kalpana Sengupta and Dr. Diari Muhammad. In a short while, I'll be introducing them. Well, I would like to wish all my colleagues Ramazan Kareem. After 2 days, Ramadan starts. So now, as usual, we are having a question. I would like to request the viewers to write, who is this scientist? You have about 2 minutes. If you answer, Dr. Tawfiq will give you a token of appreciation. Well, beautiful Dubai. It is the best time to come and visit this beautiful city with best climate. And as you know, Dubai wants to be the best city in the world. You are seeing here the Burj Al Arab, the first 7-star hotel. And as the ruler of Dubai, His Highness Sheikh Mohammed bin Rashid Al Maktoum said, I want Dubai to be #1 in the region, not only in the region, but in the world, inshallah. In many aspects, it is #1 in the world. Well, on behalf of members of Dubai Pediatric Club seen here in different conferences, and on behalf of the members of Organizing Committee, myself, Dr. Joshi, Dr. Kalpana, Dr. Diari, Dr. Amir, Dr. Ayman, Dr. Rafia, Dr. Srinivas Pandari, Dr. Leila Baghi, and Dr. Khalid Rashid. Once again, I would like to welcome all viewers to this webinar. Well, our sponsor, Dr. Tawfiq, the country business manager of Vitabiotics UAE, who always helps us. Well, about the future events, on 17 and 18 May 2025, we will have our 11th annual Dubai Pediatric Club Conference in Dubai at Duset Thani Hotel. I would like to welcome all viewers to come and join us. There is free registration for that, and we will be covering all subspecialties. We will have workshop, master classes, presentation by international speaker, poster presentation, panel discussions, and a lot of other activities. Well, I would like to give a brief history of allergy and then introduce our speaker. Well, Lucretius said, was a Roman philosopher and a poet of the 1st century BC. What is food to one is to others bitter poison, and it holds true today also. Well, I always start the memory of Hippocrates, the father of medicine, with his famous quotation, first do no harm. Please remember. Well, since today is allergy, asthma, Hippocrates in 400 BC was the first to use the term asthma in a Greek for wind or to blow, for panting and respiratory distress, which today also we call it asthma. Well, the father of pediatrics, the 10th century physician Razi, who described allergic rhinitis first time. Well, our question now, Dr. Tawfiq, we will stop. If somebody has answered, we will give a token of appreciation. The concept of allergy was originally introduced in 1906 by the Viennese pediatrician Clemens von Pirquet. after he noticed that patients who had received injections of horse serum or a smallpox vaccine usually had quicker, more severe reaction to second injection. Pirquet called this phenomena allergy. He coined the term allergy. From the ancient Greek word allos, meaning others, and ergon, meaning the work, just to remember. Well, Pirquet was the first professor in Harriet Lane. Pirquet is primarily remembered for his eponymous tuberculin skin test and for imparting the term allergy, as I said. Pirquet not only solved the riddle of the serum sickness and developed the concept of allergy, but also made contribution to study of nutrition and aging. Well, something about the allergy in Europe in 1963. A new classification scheme was designed by Philip Gale and Robin Combs, both immunologists from UK, that describe 4 types of hypersensitivity reaction known as type 1 to type 4. You know Combs as a Combs test, very famous. With this new classification, the word allergy was restricted to type 1 hypersensitivities, also called immediate hypersensitivity, which are characterized as rapidly developing reaction involving IgE. And a major breakthrough in understanding the mechanism of allergy was the discovery of the antibody class labeled immunoglobulin E. And it's interesting to know that IgE was simultaneously discovered in 66-67 by 2 independent groups, a Japanese group heading by Ishizaka at the Children's Asthma Research Institute and hospital in Denver, who was in Denver, United States that time, and Gunnar Johansson and Hans Benisch in Uppsala, Sweden. And they published this paper in 1969. This was the landmark paper. Well, you see here, Combs, Gale, Ishizaka, and Johansson and Benisch, pioneers, remember them. Well, about allergic rhinitis, as I first said, the accurate description is from the 10th century physician Razi, who first described also measles and difference between measles and chickenpox. Pollen was identified as the cause in 1959 by Charles Blackley, and in 1906, as I said, Pirquet determined the mechanism. Well, you are seeing here, Pirquet, this is Belashik. Belashik is a Hungarian a pediatrician who first described the Schick test for diphtheria, became very famous. He, in fact, was working with Pirquet in coining the term allergy. And here was Robert Koch and Charles Manteau. He was a French scientist. In French, it is called Manteau, not Motu, Manteau, but Manteau, very famous for Manteau test. Well, about the American Academy of Allergy, American Academy of Allergy, Asthma and Immunology, founded in 1943. The organization was originally called the American Academy of Allergy. From 82 to 91, it was called the American Academy of Allergy and Immunology. And since then, it has been called the American Academy of Allergy, Asthma, and Immunology. And in Europe, a working group on pediatric allergology was formed in 1984, which rapidly developed to become the European Society of Pediatric Allergology and Clinical Immunology, ESPACI, in 1988, with its own journal, Pediatric Allergology and Immunology. This organization worked together with European Academy of Allergology and Clinical Immunology to form section of pediatrics within this in 1996. They joined together in 2001, and the pediatric section is working now to develop the pediatric allergology across the Europe, just remember. And a working group, she's the Luisa Businko, working group on pediatric allergy and clinical immunology in Rome. Professor Businko of Rome gathered a number of Southern European pediatric allergists, proposing the founding of a working group on pediatric allergy and clinical immunology within the European Society of Pediatric Research. Here you are seeing, of course, the other pioneers. I'm not going to introduce all of them. Well, about the founding meeting of the working group took place in Porto in November 1984, and the working group administered by the Italian, initially by Dr. Bosinko, and from this by Jean Mendaro. Just history. Well, she is also Dr. Helen Borough, a professor, consultant in pediatric allergy and immunology, children's allergy services. She was the head of this service from 2015 to 2023. Professor Nick must be knowing. And just as it is estimated that allergy affects lives of up to 21 million people in UK. And allergic disease has been described as modern epidemic by the WHO. And between 5 to 8% of all children in UK live with food allergy. Today, Professor Nick will explain. And since today they will discuss about allergy, they may say about GINA. I would like to say GINA was launched in 1993. GINA guidelines, everybody knows, in collaboration with National Heart, Lung, Blood Institute, National Institute of Health, USA, and the WHO. And just GINA's program, and not that, just to know that 1993 GINA was established, an area that is allergic rhinitis and impact on asthma. This was the WHO initiative, 1999 it was established. Later on, remember this name, John Bosquet. He's the French immunologist from France. In 2008, 2010, 2016, actually they made the guidelines for allergic rhinitis and impact on asthma, which is called area. Just to know this, since 1999, it is there. Well, many people with allergy and asthma, if well controlled, they are the world champion and even Olympic, and they have won many medals in Olympic. Just remember, if well controlled, you can be an Olympic champion. Well, about our speakers and panelists, as I said, our speaker is Professor Nick MAKWANA. I will just introduce him, and panelist Dr. Mahesh Katre, consultant pediatrician, pediatric allergy specialist from UK, presently at NMC Specialty Hospital, Dubai, also in NMC DIP. Our moderator, Dr. Kalpana Sengupta, Senior Consultant Pediatrician, Head of the Department at NMC Specialty Hospital, Dubai. She is the Secretary of the club. And Dr. Diari Mohammed, Senior Consultant Pediatric Surgeon at Al Jalila Children's Hospital, Dubai. He is the Chairman of the Academic Affairs. He is traveling. He said he will join, but we will see. Well, our speaker, Professor Nick MAKWANA, he is honorary professor, Institute of Clinical Sciences, University of Birmingham, consultant pediatrician, pediatric allergy department of child health, Sandwell and West Birmingham, NHS Trust, UK. He is the group director, Women and Child Health, Sandwell and West Birmingham, NHS Trust. Pediatric MBCHB curriculum lead, University of Birmingham, and former chair pediatric allergy committee from 21 to 24. Well, I end by quotation from Charcot, the French neurologist. Disease is very old and nothing about this has changed. It is we who change. As we learn to recognize what was formerly imperceptible. Well, my references, beautiful Dubai. Thank you very much. Now I'd like to request Professor Nick to start his talk, and after completion of his talk, we'll start question and answer. Professor Nick, please.
Thank you for that introduction. That's very kind of you. I'll just share my screen. Hopefully it'll all work because we did try earlier. Right. Let me just check. Is that sharing?
Yes, yes.
Yeah, you can. Hopefully you can see my slides. Yeah.
Yes, yes.
Good.
Absolutely.
All right then. Brilliant. Okay then. So yes, thanks for the introduction. I'm Professor Nick MAKWANA and I'm from Birmingham, UK. This is a picture of our new, probably not as it's exciting as a Dubai hospital, but we've just opened a new hospital 3 months ago, which is the only new hospital in the UK for, I don't know, about 100 years or something. So very lucky to be working there. Um, so from my point of view, I started my job in 2007. And one of the first things I saw was this article saying allergy cure just 3 years away. And I thought I'd chosen the wrong specialty to go into because I thought I might need to find another job if allergy is going to be gone. But, as we know, that's not the case. And I was just looking through sort of some of our media cuttings. And these are some of the children and young people, unfortunately, who died of allergy either at school or at restaurants by accidental ingestion of a food they were allergic to. And two of the most high profile cases in the UK recently have been these are Natasha and Owen. Natasha, who died after eating a sandwich that contained sesame, which we didn't know about, and Owen, who unfortunately died after eating a burger that contained milk, which they didn't know about. So allergy is very much in the fore of the UK sort of medicine groups, really, and very important for us to get right. So what I was hoping to cover, I might go over slightly over, but obviously the team can stop me if needed. I think I was asked to cover food allergy mainly and talk about non-IG and IgE, think about diagnosis and management, a little bit about eczema management, because I think it really does impact on food allergy as well in many ways. If we have time at the end, a bit of allergic rhinitis management, including immunotherapy. And then throughout my talk, you'll see I'll talk about future directions in food allergy, particularly. So we're thinking about food allergy. One of the things we talked about just now is the massive food allergy epidemic. And it's difficult to know whether that's a true epidemic or not. So, I mean, this is a paper actually from this month. So I pulled it off from this month. And there's actually very few good studies of allergy prevalence over time using really good, robust methodology. And this is probably one of the best ones because it's done on a very sort of focused population in this tiny island just off the coast of the UK called the Isle of Wight. So it's a very sort of defined area. And they looked at two birth cohorts, and they looked at one birth cohort from 1989 to 90 and one born 12 years later in 2001 to 2002. And the significance is that during this time, a lot of other reports showed an increased incidence of food allergy, as well as admissions for food anaphylaxis. But what you can see from this sort of study is actually sort of cutaneous sensitization, so looking at sort of skin testing, looking at the incidence of challenge probe in food allergy, and sort of the reported adverse reactions of food have actually remained quite stable at, I think what Dr. Sorob's already mentioned, around 5 to 8%. And this sort of finding really mirrors those of the US and also of Australia as well. So what they found is that, children born in decades apart had very similar levels of sensitization. And it's sort of stable with what we sort of see in practice, which I'll talk about a bit later. So, I mean, this study, I suppose, questions whether there is an increasing incidence of food allergy in high-income countries, or is it staying stable? And why do we think there is an increase in incidence? So I think, firstly, the diagnosis is very difficult. So I think it is susceptible to overdiagnosing food allergy. And you'll see later on when I talk, our diagnostic tests are only good as the history we take and the people who do them. And so that might be one of the reasons, is that people are relying too much on diagnostic testing for it. And also the second issue, as I've shown you from those media cuttings, is our social response to food allergy. There's been a marked sort of concern in food allergy over recent years, and this is partly fueled by increasing awareness, the increasing diagnosis, and that can lead to heightened anxiety and worry. So that might also be leading to sort of diagnoses as well that may not be correct. I mean, saying that, obviously there is clear evidence that the rates of food-induced anaphylaxis have been increasing in our UK hospitals. And why we're interested in it is because obviously we're paediatricians, and you can see in that top line there, it is the 0 to 14-year-olds incidence of anaphylaxis has gone up the most. But what's being very reassuring is actually case fatality has actually come down. So, you know, we're managing it better when it does happen. What foods cause these food allergic reactions? So we have, so in the sort of under 16-year-olds, we've got mainly nuts actually, and milk. And then in the over 16-year-olds, so the adults, you can see here, we have, again, nuts being the major part. So either tree nuts or peanut or unidentified nuts. So nuts sort of certainly in the adults, and in children, actually milk and nuts. And you can see that sort of changed over time. So milk has become a lot more of a prominent allergen causing reactions over time. And that's all reflected in the service I run. So obviously when I started in 2007 at our hospital, we only had 2 clinics a week and saw about 700 patients per year. But now fast forward to 2025, we have 9 clinics per week. We see 3,500 patients per year, and we've got a much bigger team now to manage that. We have an MDT clinic, and we offer lots of innovative treatments for allergies, both sort of food and non-food allergy too. So let's have a quick sort of think about IgE mediated allergy. So this is, I'm going to do a couple of cases. My poll doesn't work, so just have a think about the answer, all right? So this is Justin. He's 5 years old and he's in the ED waiting room. He eats a cracker with peanut butter. He gets immediate eye swelling and urticaria, and then the nurse brings him to see you, okay? And these are the options. So you can either give him an antihistamine, give him oral prednisolone, give him an adrenaline auto-injector, a combination of A and B, or A, B, and C, or think of something else. I'll just give you a couple of seconds, just in your own mind, think what you would do if you saw this young man with that history. So he's got no other symptoms, just eye swelling and urticaria. Okay. So in this case, he's given some chlorphenamine. The swelling settles over 4 hours, and he goes home and is told to avoid all nuts. And we'll come back to him a bit later on, okay? But what this sort of shows is that really IgE-mediated food allergy, and actually non-IgE as well, is a multi-system disorder. It can affect any organ in the body, from, you know, giving you a bit of conjunctival injection to cardiovascular collapse. So we have to think about, when we think about the sort of treatment, that multi-system nature of presenting symptoms. So non-IgE mediated allergy is the one that's always more difficult, and it's certainly across Europe. So this is European data looking at milk allergy specifically and looking at the incidence of non-IgE and IgE. And you can see this is the UK, second from the start of the chart. And actually the dark chart is IgE and the light grey bar is non-IgE. And you can see overall, we've got 1.28% incidence of milk allergy, but a majority of that is actually non-IgE as opposed to IgE, which is actually quite interesting. So again, we have to think that a lot of what we see in our clinics from a milk allergy aspect certainly is more likely to be in non-IgE symptoms. And I think non-IgE is more difficult. So IgE mediated, most people generally understand what the symptoms look like and the timing, and we'll talk about that in a minute. The non-IgE, you can see that list. Actually, a lot of that is also common childhood kind of conditions and symptoms. So it can be a lot more difficult to differentiate what might be driven by milk. And obviously at the extreme end of non-IgE, we also have conditions like eosinophilic esophagitis and food protein-induced enterocolitis syndrome, which I won't be talking about necessarily in my talk, but we can touch on later if wanted during the discussion if needed. So how do we diagnose food allergy? So really the key thing is getting your history right. And, you know, we're always told in 95% of the diagnosis is your history. And I think that's nothing truer said that in allergy, that's definitely the case. And the first thing really is, what is the allergen, and is it an allergen typical for age? So, you know, milk is a very typical allergen for a infant, but it'd be very unusual to have your first episode of a milk rated reaction in a teenager. So, does it make sense? And also really important to ask, what is the dose of milk they can tolerate. So it's not about can your child drink milk, but how much can they actually drink? Because obviously, if a parent says, yes, they can drink like, 10 mLs, that's not normal for a 1-year-old to be able to drink. A 1-year-old should be able to drink, a good 500 mLs of milk throughout the day. So actually making sure that what they're saying makes sense. And then, if there is uncertainty, then obviously these are the foods that cause 95% of reactions in the UK. So egg, milk, peanut and other tree nuts, shellfish, whitefish, wheat, and soya. So those will cause 95% of reactions in the UK. Then the other things that's important to ask about is a timing of the reaction. Then an IG-mediated reaction will normally occur within, 5 to 10 minutes generally, but certainly not beyond 2 hours. So again, if the reaction is beyond 2 hours, you have to think really hard about is this IG-mediated allergy? What are the severity of the symptoms? And we'll come back and talk about those a bit later. But again, whether it's hives and angioedema, or is it anaphylaxis with respiratory or cardiovascular symptoms? What was the route of exposure? So certainly aerosolized milk and aerosolized fish can cause reactions. Obviously in the UK, we've had a recent child who's had actually reactions through exposure through eczematous broken skin. What was the quantity of food that provoked the reaction? Because again, it'd be odd, for someone to eat 20 peanuts and then have anaphylaxis. What you normally expect is much smaller amounts. So again, was that the food that provoked the reaction? What treatment was given, and what was a subsequent food avoidance? What have they done since? You'd be surprised how many people said, oh, I gave a cashew, he got lip swelling and hives. I wasn't quite convinced, so I gave another cashew and then, ended up in hospital. So people do that. And then really important in allergy is concomitant allergic disease. And I'm sure you're all familiar with the atopic march with sort of eczema and food allergy sort of beginning early on in life. And then as you get older, you tend to grow out of food allergy and eczema, but then you develop rhinitis and asthma. And they all interact. So, if you've got badly controlled eczema, then you're at higher risk of developing allergic food sensitizations. So actually, if you've got a child who's already got a food allergy, you want to get the eczema control really quickly and well, to try and prevent new sensitizations and new allergies. If you've got asthma and food allergy, we know that if you've got poorly controlled asthma, you're at higher risk of having a anaphylactic reaction if you ingest something you're allergic to. So you must make sure that asthma is well controlled. And we know that obviously if you've got poorly controlled rhinitis, you're more likely to have poorly controlled asthma. So actually, if you've got both going on together, you need to make sure your rhinitis is controlled well as well. So they all impact on each other. You can see that at any age, you can have all four going on at the same time. And that's why our clinics are MDT, because we really need to think about all of these. We can't really ignore one because of the impact it has on the other. So non-IG, again, we sort of talked a little bit about sort of symptoms there. So, eczema is a very common childhood condition. And the question is, could it be driven by a food allergy? And normally, eczema driven by a food allergy, first thing you need to be thinking about is getting the eczema control right. We'll talk a bit more about that later. But if you're controlling the eczema with the right creams, they're complying, and the parent sort of feels that every time they go food X, the eczema flares up 2 to 24 hours later, then that could be a non-IgE component food allergy. And that's the sort of difference. The flares often occur 2 to 24 hours later, not within sort of minutes. Again, gastroesophageal reflux that is resistant to treatment. Could it be a non-IG mediated food allergy? A very well child with bright red blood in its stools who's just converted to formula milk, for example, that might be a presentation of non-IG allergy. Infantile colic. So typical colic is, in the evening between 4 and 8, fractious child, but settles down. A child who's got sort of colic type symptoms related to milk allergy, is very difficult to settle. They're often, very upset, crying, for, majority of the day and night. So again, that gives you a slightly different picture. Constipation, again, normal history of constipation is that they strain and produce a very hard stool. In constipation, that might be driven by a non-Ig mediated food allergy. They strain and produce a soft stool because it's a dysmotility issue rather than a water sort of solidifying issue. So yeah, so there are some clues in there that might help you push towards a non-Ig type allergy. Obviously, examination is going to be really important because either they might be restricting foods or you might have to tell them to avoid a food. So we need to be very clear what their height and weight is doing at that moment in time, and then what we will be monitoring going forward. Obviously, looking for features of poorly controlled asthma, looking inside the nose for inflamed turbinates, and looking at eczema severity together with side effects of steroids if they're being given steroids inappropriately. But if they're given appropriately, actually there's good evidence that there's not really short or long-term problems. So you've got your history, you've got your examination, then you'll be thinking about doing some tests. So the tests we've got for IgE-mediated allergy is either skin test or specific IgEs, as you can see there. So when we think about sort of skin tests and specific IgE, one of the sort of myths is that the bigger your wheal or the higher your value of your blood test, the more likely you are to have a severe allergic reaction. That's absolutely not correct. What the size of the test tells you is your likelihood of being clinically allergic. So how I might sort of describe this is, so if you get a child who's eaten a peanut, within 10 minutes got lip swelling, eyes swelling, hives all over the body, you give a dose of antihistamine, and within a couple of hours everything's settled, my pre-test probability is that actually this child's 95% likely to have a peanut allergy. I'll do a skin test, and the skin test result will be 6 millimeters. Anything 3 millimeters or more is classed as positive. So my post-test probability has now gone up to 99, 100%, and I'll make a management plan for peanut allergy. So we might have another history where I ate a peanut, 6 hours later, I had a bit of an itchy throat. I got a bit of a tummy ache later on that evening. I felt a bit itchy overnight, and then I vomited once. I might say, I don't know, 40%. My pre-test likelihood is that this is allergy, peanut allergy. I'll do a skin test. The result will be exactly the same at 6 millimeters. But what we know is that approximately a third of children without a good history who have a skin test of less than 8 millimeters will tolerate peanut without any problems. So I will put that child forward for a food challenge. So you can see the skin test result is exactly the same in both cases, but the history has driven me to a completely different outcome. And that's because, remember, none of these tests prove allergy, they prove sensitization. It's your history that proves the allergy. And that's why really we don't do panels or specific IgE, because unless they've eaten the food and got a clear they've tolerated or not tolerated it, specific IgE panels really are not helpful because they only tell you about sensitization, not about allergy. Generally, we prefer doing skin tests. We find them more accurate anyway. They're simple, relatively painless, inexpensive because you can get many out of one vial. It provides immediate results, so the patients like that because you make a plan straight away. And when they're negative, they've got really high negative predictive value. Obviously, if they're positive, as I've said, they're only as good as your history. And you can do several tests simultaneously. You can get false negative results, particularly if they're taking antihistamines in the preceding 48 hours. If children got severe eczema, then obviously they might not have an area of skin that we can actually use to do the test. So yeah, sometimes we can't do it. So I was one of the authors of the National Cow's Milk Protein Allergy Guidelines, and the section I had to sort of look into was actually testing for cow's milk protein allergy. So these are sort of these are some of the studies I looked at to look at that kind of testing for specific IgEs, and these are sort of the cutoffs we had. So this is, if you look here, so these are specific IgE cutoffs for a positive predictive value between sort of 90 to 95%. You can see it varies between 5 and 88. All right. So, that's a huge range of cutoffs there, which is again why it's not as helpful. All we can really say, and it's the same with the specificity again, you can see it ranges from 0.35 all the way to 32. So all we can really say is probably higher values are going to be relevant in older kids and lower values are probably going to be relevant in younger kids. But actually, there's no clear cutoff. We can say if you're above this, you are truly allergic. Even skin testing, we like skin testing. This is a study actually from this month again from Singapore. They were looking at evaluating the diagnostic accuracy of milk, egg, wheat, and peanut skin tests. And what you can see is actually overall, there's pretty poor diagnostic accuracy as well. Apart from egg, I suppose, is a bit closer. And what I'm showing you here is obviously the ROC curves, all right? And the ROC curves really should look like this red line. So a really good diagnostic test would have an ROC curve that looks like that. If an ROC curve is down the diagonal, generally it means it's useless, all right? So again, you can see most of these drive down the diagonal. So again, they're only as useful as your history. So again, there's no point testing for foods people haven't eaten or are eating without any problems. Obviously, there are a few sort of limitations of the study. It's retrospective. Obviously, these are proven by food challenges. So these are kids who were put forward for food challenges. People who had larger skin tests wouldn't have been put forward for a challenge. But again, it gives you an overall idea that actually the tests are only as good as your history. So after my history examination and testing, I'll have 3 outcomes. This is definitely a food allergy, avoid. Definitely not a food allergy, go and eat. Or I'm not sure, in which case we'll do a food challenge. And the food challenge really is the sort of gold standard for food allergy, where we give the child graded doses of food in hospital. If they tolerate the top dose, they're not allergic. If they react at any point, we give them treatment, they're confirmed as allergic. If they can't get to the top dose, then we don't know, because what the top dose is a dose that's appropriate for that child. So if they only get to like, a third of the way through, what I don't know is if they eat more, will they react or not? So that I will call that inconclusive. But what we will then know is you can tolerate a certain amount, hopefully without problems. So what about non-IG mediated? So IG is a bit easier because we know what the mechanism is. So we've got a test to try and, get that IgE tested. Non-IG, unfortunately, we don't actually have a mechanism of why it happens. We just know it does. So we have this sort of algorithm in the UK called the IMAP guideline, which is mainly for milk because that's what we see most non-IG related symptoms to. So you can, if you Google IMAP milk allergy guideline, you'll get this flow chart. But basically, the only way to diagnose a non-IG mediated allergy is by a targeted elimination diet. So, for example, I saw a baby in clinic today who had quite severe eczema. Mums were treating it correctly. They're on a formula milk. So the only real way I can now decide if there's an element of milk allergy driving it is I exclude milk completely for 4 weeks to see if the symptoms improve. And then you reintroduce gradually over the next 4 weeks to see if the symptoms return. And if the symptoms improve and then return, that will confirm a non-IG mediated allergy. And there's no real data on how long you eliminate for, but most recommendation are between 4 to 6 weeks. So, no other tests will really help you. People have tried patch testing, looking at calprotectins, but none of these are actually useful for diagnosis. Once you've got your diagnosis, the option is obviously avoidance. And it is difficult because you can see the products on the right-hand side here contain milk, the products on the left don't. And you can see how similar they look and how difficult it is to shop. And that's why it takes 40% more longer to shop if you're an allergic person, because you've got to double check every single food label, because they can change the ingredients anytime without telling you as well. So every time you go, you have to check, because you might have been all right with the food for 5 years and then suddenly you'll react to it. And then obviously, if you do eat something you're allergic to by mistake, then it's recognition and management of reactions. So when we sort of think of recognition, how I explain to parents to make it easier for them is anything in front of the teeth. So lip swelling, eye swelling, hives, it's all outside, it's in front of the teeth. That just needs an antihistamine. Anything behind the teeth, so that's tongue swelling, breathing difficulty, wheezing, getting pale or drowsy, that's gone inside, and that's what needs adrenaline and an auto injector. So we educate all family members and carers, including school staff, on recognition and management of reactions. They all have written treatment plans. They must treat early. So if they're not sure if it's anaphylaxis or not, just treat it. It's better to do that than not to give it. They must carry medications at all times, medical alerts if they want to, and then obviously planning for overseas travel as well. And so your reactions vary by cause. So you can see here, drug reactions are generally more cardiovascular, as are venom reactions, whereas food-related reactions are more respiratory. So, and that's why that control of asthma is so important. Because if you've already got poorly controlled asthma, you eat something you're allergic to, you're more likely to have a respiratory anaphylaxis, and that's what the children who die of anaphylaxis have died of respiratory anaphylaxis. And almost all of them have had asthma, and the majority is poorly controlled. So one of the things we always say, if you have an allergic reaction, for most people is lie down because of that, pooling of blood. Because again, what the data has shown us is more people have died when they're sitting than when they're lying down. And again, that's because certainly in adults, you'll get pooling because of that hypotension. In children, it's slightly different because obviously we're more likely to see respiratory. So we say if they're in a comfortable position, you leave children in the position they're comfortable in. And I think we've covered this. So teenagers and young adults predominate in death series, and that's because obviously they take more risks. They begin to think they're invincible. They don't like carrying the medication around. They don't want to be different from their peers, so they'll try foods they wouldn't have tried if their parents were there. And the treatment is, as I've said, adrenaline. Okay, so it's really important because people will get anaphylaxis and they'll give, nebulizers, they'll give antihistamines, they'll give steroids, but actually the treatment of anaphylaxis is adrenaline, so that's what we should be giving. And you can see everything else is second line. So wheeze, yes, salbutamol, absolutely. Stridor, nebulized adrenaline, hypotension, fluids, and right down at the bottom, you can see antihistamines and steroids are third line. So anaphylaxis, I am adrenaline, end of story. And obviously, sort of out in the community, the two brands we have currently available are EpiPen and Jext, both, similar kind of actuation mechanisms. But if you do give them, the patient must be trained on how to use it, either by yourselves or you need to direct them to appropriate sort of support. And I normally say you should get a trainer pen and practice with it every month, because then they'll get used to using it. Because most of the time mistakes are made, because the idea is you're very unlikely to need your auto injector. That's what the data shows us. So if you do need it, you've not looked at it for 2 years and then suddenly need to use it, that's when people start making mistakes. And so there's been an update recently in the indications for adrenaline. So these are the absolute indications for adrenaline. So any previous anaphylaxis, because we know if you've already had one anaphylaxis, you're at higher risk. Food allergy and coexistent asthma, and I think we probably sort of explained why. Exercise-induced anaphylaxis, because they don't know how much exercise will trigger the anaphylaxis. Idiopathic anaphylaxis, so you've definitely had anaphylaxis, but we don't know what to, and therefore we can't tell you what to avoid, so you remain at risk. And then BM wasting allergy in untreated patients who haven't received immunotherapy, because only if they've got a higher risk of re-exposure. So these are people who are beekeepers or live on farms where there's bees, or any other reason you might be exposed to a bee. And then there's some relative indications which are not evidence-based, but considered a sort of expert sort of opinion. And again, most of those people can see why you would do that. And if you've got 2 or more of those, then we would strongly consider. But like I said, this is more expert opinion. There are written treatment plans available. These are our British Society ones. They're downloadable wherever you are. So all across the world, you can get these downloaded and use them. Really important to give them a written document, which the school can also have. So they update their own management plans in the school as well. The other thing I now do, because most people aren't going to carry a bit of paper around like this anymore, because obviously times have moved on. So we use an app called Digital Health Passport. It's a free app. You can upload your completed management plan onto that. So most people will carry their phones everywhere they go. So they will be able to access it on their phone if they ever need to. And the other good thing about that app, it does have like videos of how to use your auto injectors and stuff like that too. Clinic follow-up is really important for IG-mediated allergy, certainly. What's it's been shown is that it improves parental knowledge of allergen avoidance. it helps you manage allergic reactions better. They're better at using their treatments, and they get significant reduction in allergic reactions because they understand it. And also we can test to determine resolution of allergy. So, you know, for milk and egg, we know that 80% of kids will grow out of their milk and egg allergy by the time they're 5 to 6. So we do yearly testing. Whereas for peanut allergy or nut allergy, we know you're unlikely to grow out of your nut allergy. So we tend to test every 5 years. So 5 years old, 10 years old, and 15 years old. And if we think about Justin at the beginning, you remember he ate a cracker with peanut butter and had a reaction and was told to avoid peanut. So about 3 years later, he's in McDonald's, he eats a McDonald's burger and promptly has anaphylaxis. And there's no peanut around, you know, so they couldn't understand what happened. So obviously he came to clinic, and then when we tested him, his peanut skin test came up negative. So we had to double think. And then parents, we went back a bit more in the history, and it was a sesame cracker that they put the peanut butter on. So when we tested for sesame, the sesame came up positive. So actually been avoiding the wrong thing for the last 3 years. It was lucky he hadn't had exposure before then. And that's why even if you've got really good history, it's important to confirm, because like I said, just knowing that that sesame cracker had sesame in it would have been important, but obviously had been missed on multiple occasions. So what does the future look like? Well, there's obviously about when to wean and with what. And we've had 2 big sort of landmark studies in the UK, which was the LEAP study and EAT study. The LEAP study was looking at early peanut consumption between 4 and 11 months old. And you can see actually, if you did it as you were told to do it, you actually basically didn't get peanut allergy. And these were high risk children. So these were children with either eczema and or egg allergy, which we know they've got an 80% risk of developing peanut allergy. You see that dramatic drop down. So actually, I'll show you what our document says, but our recommendation now is get peanut in early into the diet. The EAT study was slightly different. So that looked at introducing allergens early in a sort of just a general population. So remember, the LEAP study was in high-risk children. This was in the general population. And it didn't work quite as well. And I think that, and they looked at sort of peanut, egg, it was milk, sesame, fish, and wheat. So early introduction of all of those foods, because those are the ones, like I said, produce 95% of reactions in the UK. But it was very difficult to stick to the protocol of introduction. And that's what I think the issue was. The people who did stick to the introduction correctly, you can see there was a significant reduction in allergy. And it was particularly good, again, for peanut. So early introduction of peanut prevents peanut allergy. And actually not too bad, as you can see, for egg as well, which is the bottom one. But it was very difficult for people to stick to the protocol. And that's where the problem lies, with a population-based approach. And then we have this, the BSACI, again, the British Society guidance on early allergen weaning. And again, this is freely available on the internet for anybody who wants to do it. We give this to parents who have, you know, new babies with other children with allergies to try and help them decide how they're going to wean their children. We've obviously now moved to what we call active allergy management. So in 2007, when I started, all we could do is say you're allergic, avoid the food, make sure that the rest of your diet is okay, manage reactions, and we'll test you until you've grown out your allergy, hopefully. Fast forward to 2020, everything changed. So now we're introducing foods early to induce tolerance before allergy develops. We are giving foods that, you know, so before, if you were milk allergic, you were told to avoid all milk, but actually now we sort of say, baked milk and baked egg are all right, even if you're milk or egg allergic, because 80% of kids are fine with those. And there's some evidence that will help you grow out your allergy quicker. And then we have active attempts to induce tolerance using desensitization or immunotherapy. So yes, I think we've covered that kind of thing here already. So talking about sort of immunotherapy particularly, that's been sort of a massive game changer, I suppose, in the world of allergy and treatment of allergy. And this is sort of very sort of simple graph of how immunotherapy works. Obviously, you're eliminating, then you do an induction. So you can start giving tiny doses on a daily or weekly basis. And now some kids are just so sensitive, they can't get beyond that, as you can see. And those are non-responders, and they just, you know, you won't get them to be desensitized. Another group will get part of the way through the protocol, but won't be able to go above that. Now, that still makes a massive difference to your quality of life, because if you've gone from no milk to having 50 mLs of milk and been okay with that, then actually that means you can now eat an ice cream, you can eat foods containing milk, which, and you won't react. So it still has a massive impact on quality of life. And then you've got those kids who get right to the top dose and can tolerate it in normal portions. And that's a game changer for them because they don't have that worry or anxiety about eating out, going to other people's houses, and they can tolerate that food. But the important thing is to maintain that desensitization, they have to eat that food regularly. Okay. So if you don't eat it, you will then become potentially allergic again. All right. So you have to continue eating it. There are some kids who will hopefully over time grow out the food allergy, and we might speed that up with immunotherapy. So that's what immunotherapy does. But obviously there is a risk to that because you are giving a child something they are allergic to. So we've done milk and egg for a long time in our service. We're just with native products, so native milk and native egg. But peanut has always been a bit more difficult because of that higher risk of anaphylaxis. So obviously we've had approval over a couple of years ago of Palforzia, which is oral peanut immunotherapy. And at the moment, we're in the last sort of trials of epicutaneous peanut immunotherapy, which is obviously in theory safer because you're not exposing it through the gut. So better diagnostic tests. So we now do component testing. So obviously, when we do specific IgEs or skin testing, we're just testing a whole mushed up peanut effectively, for example. So, but what we know is actually when you're allergic, you're not allergic to the whole peanut. You're allergic to one of the proteins in the peanut. So you might be allergic to the red and the yellow, or the green and the brown, or just the brown. And actually, which one you're allergic to will depend on what your reaction will be like. So, for example, we know that if you're only allergic to ARA-H8, so if I do let's say you tell me that you get itchy mouth when you eat a peanut, okay? Now, actually, that could just be oral allergy syndrome and not a peanut allergy. But before, we didn't really have a test to work out if it was. But actually, if we do a component test to peanut and you're negative to all the other ARA-H's, they're the ones that are responsible for true peanut allergy. ARA-H8 is the cross-reactive component to pollen. And if you're only allergic to ARA-H8, that means you're unlikely to have a severe allergic reaction and you've got oral allergy syndrome. So actually, you can make a completely different management decision based on that information. So that's a really sort of a big jump in our allergy testing as well. The other big thing for us, certainly in the UK, has been better food labelling laws. Since obviously Natasha died, there was an issue with pre-packaged food and how it's labelled. But now that also has to be labelled, and that's by legislation. And that came in October 2021, making it safer for these patients to eat out. So one of the things I talked about was eczema. And I think eczema is a big part of our allergy clinics because everybody assumes that if they find out what their child's allergic to, their eczema will miraculously vanish, okay? But eczema is a skin condition, not an allergic condition, okay? So you might have eczema. So if you've got eczema, you may also have Ig-mediated allergy. That'll be based on your history. Or you might also have a non-Ig-mediated allergy, but that's based on your treatment, okay? So I'm just gonna give you another case. So this is Jay, who's aged 4 months old. He's been referred to the allergy clinic because he had eczema from birth. Mum stopped breastfeeding and changed to formula at 4 weeks old. He uses creams, but mum says they're not really helping. And she wants to know what her child is allergic to, all right? A very typical patient in our clinic. So these are your options. So again, just have a think about what you would do. You perform a specific IG to milk, egg, and wheat. You perform a food panel specific IgE. You change the eczema creams. You discuss compliance with creams. You refer to the allergy clinic for skin tests. You perform a food allergy specific panel and then refer to clinic, or you might do something else. Just have a bit of a think what you might do. Okay, so what I would normally do in this scenario is make sure that the creams are the right creams and they've got the right strengths of steroid for the level of eczema they've got. And we make sure they're complying with their creams correctly before we did anything else. Because there's no other history of an IgE mediated reaction. And we've got a nice guidance in the UK for atopic eczema, which makes it clearly. So if you've got eczema, you consider food allergy in those who've reacted immediately to food or got uncontrolled severe or moderate atopic eczema, particularly if they've got another organ infected that may be affected by a food allergy, like the gut. And obviously, in inhalant allergy, it's more to do with seasonal flares, or if they've got other airway problems that might be also related to aeroallergen sensitization. Treatment is difficult, and that's where the problem lies. I think getting the treatment right is really hard. There's this really good evidence base for eczema treatment called the Global Resource for Eczema Trials. Again, freely available on the internet. It gives you all the kind of evidence behind eczema management. One of the things that everyone always did was give bath additives, but again, there's this trial published in the BMJ, so there's no actual real additional benefit by putting bath additives in. So generally, we avoid those now unless there's another reason to use them. The other thing that people always worry about is steroid. And again, people often say use it twice a day, but again, good evidence now that once a day is just as effective as twice a day. So actually that, again, might be a better way of using it and might reassure families that they're not having to put it on twice a day. The other thing that happens is this. So people are worried about using steroid. So they give 2 or 3 days and the eczema gets better, then they stop it. Then the eczema flares up again. Then they give another 2 days. Then they stop it. Then the eczema flares up again. So they use like 2 or 3 days here and there and everywhere. And actually, that's probably not the best way of using steroids. And what I normally say is either for a flare, you either use 7 days or 14 days, okay, daily. So if your flare settles within 2 or 3 days, you probably need 7 days worth. If your flare takes 4 or 5 days to settle, you'll probably need, 2 weeks worth. And then depending on the level of flare, you'll step down, okay, of treatment. So rather than stepping up, I will go in with the highest strength that I need to get it under control and then step down. And there you are. So that's really how steroids should be used. And if they're used correctly, there's really good evidence there's no short or long-term side effects from them. So management, like I said, bath oils I tend not to use. I tend to use Dermol 600 if there's evidence of an infective component. Soap substitutes, you could use any creams generally, but Dermol 500 if there's an infective component. I always tell parents all the emollients are the same, all the children are different. You need to chop and change a little bit till you find one that suits your child. But once you've got one that suits your child, you've got to use it for at least 4 times a day. If you can put it on 5, 6, 7, 8 times a day, even better. And then you, again, like I've already said, appropriate strength steroid for severity. And we can talk about that later on in the panel discussion. During flares, you might give a sedating antihistamine to try and help that child sleep so they don't scratch, to give their skin a chance to heal. And if they're having recurrent flares, then I'd go to using a neurocalcin inhibitor like pimecrolimus or tacrolimus daily for a couple of months, just to keep it under control and try and get that skin to heal. So I think I've got about 5 minutes left, and I should maybe just quickly touch on really allergic rhinitis. Finally, so this is William. He's 12 years old. He's got significant hay fever symptoms of his nose and his eye. He's tried daily antihistamine. It hasn't really helped. It's affecting his quality of life. He's unable to go out and play at school. He doesn't really do sports because of it, and he's stuck indoors all the time. So he comes to your clinic. That's what's going on. Again, have a think about what you would recommend for this child. Okay, so again, Gina, obviously, Dr. Sora mentioned there's the ARIA classification as well. Okay, you should classify where this child is in your allergic rhinitis severity. And for him, he's probably in persistent and moderate to severe, if you look at that kind of protocol. And actually, nasal symptoms are the most problematic for patients. It disrupts their sleep, it disrupts their learning, it disrupts their ability to do stuff. And in his case, obviously, he's got significant eye symptoms. But certainly for nasal symptoms, the best evidence is for nasal corticosteroid. So generally, for children, we will tend to go for antihistamine first because it's easy and a lot of kids don't like stuff up their nose. But actually, you can see, if you look at terms of actual efficacy, nasal steroid is probably better than antihistamine, okay? You can also add things like leukotriene antagonists, antihistamine eye drops to help with that as well. And then, as you can see on the right-hand side here, as you get more and more severe and less controlled, then you can start thinking about specific immunotherapy as well. If you do give a nasal steroid, then it's really important to remember that the newer ones have very low bioavailability. So actually, very little steroid gets absorbed. So you can see here, so mometasone, which is a Nasonex, and fluticasone, which is Avamys, have hardly any systemic absorption. But things like becconase have quite high absorption, so we never use becconase in children, but we're happy to use Nasonex and Avamys. And the other thing that's really important to do is show them how to use their nose spray properly. Most of the time that nose spray doesn't work, because I've just told you it's brilliant, but most of the time it doesn't work is because they're not using it correctly. So you must make sure they've been shown how to use it so actually it works correctly. And again, we have this great website in the UK called Itchy Sneezy Wheezy, and there's videos on there on how to use your nose spray. And the last couple of slides I've got is just about immunotherapy. So this is, again, we talked about desensitization to food allergens. This is desensitization to aeroallergens. And we have got two sort of products we tend to use. One is grass pollen based. One is, very recently approved house dust mite pollen based. So this is sort of the meta-analysis for grass pollen. And as you can see, so the medication score, very favorable profile, so you use much less medication once you've started this. And for this, so that's the medication here, and for the symptom score, again, your symptoms are dramatically improved with sublingual immunotherapy. So actually, again, really good treatment, and there's some evidence that that may also prevent asthma if you've not already got asthma, because remember, it's all one airway. And again, if you look at house dust mite immunotherapy, this was published last month in the Lancet, looking at house dust mite sublingual immunotherapy in children between 5 and 11 years. And again, you can see very clearly a massive impact on symptom scores, nasal symptoms, and quality of life. So again, really massive impact, and we should really be using it sooner than we do. And just last month, our NICE guidelines have approved the use of house dust mite immunotherapy. Now, obviously, Grazax was already approved, but now they've approved dust mite immunotherapy as well for treatment of allergic rhinitis. This is from 12 years upwards, but I'm hoping that the 5 to 11-year-olds will come in soon because of that study. And this is William after we treated him, completely different child. He won man of the match in his cricket, so it made a massive impact on what he could do. So that's sort of my take-home message. So that's a bit of a whistle-stop tour because my talk was called Allergies in Children. So I wanted to touch on quite a few areas. So hopefully that's given you some things to think about. And my take-home messages really are, IG-mediated reactions absolutely need a referral to pediatric allergists for assessment, and hopefully that's become clear why. IG testing may be useful in selected cases, so that's with a good history and a reaction, or if for example, if you've got egg allergy at high risk of developing a peanut allergy, then that would be fine to do, but otherwise don't. History and elimination are the key to diagnosis for non-IG mediated food allergy. Again, no test will really help. If you do give an auto-injector, make sure they're trained. If they've got eczema, treat correctly. And if you're managing allergic rhinitis well, and you sort of got that sort of protocol of how to do it, and they've still got symptoms, then really slit is the way forward. So obviously, thanks to, obviously, I don't do all of this myself. I have a fantastic team who work with me. And I think pediatric allergy certainly is definitely a team sport. And that's what makes a difference. So thanks for listening.
Thank you very much, Professor Nick, for this excellent informative talk. Now I'd like to request Dr. Mahesh, consultant pediatrician, pediatric allergist from UK, presently at NMC specialty and DIP, Dr. Kalpana Sengupta, senior consultant pediatrician, head of department, secretary of the club, to join us. Dr. Diari will join us later if he can. And we have received some questions. I'd like to request Dr. Kalpana first to ask those till the viewers are writing the question in the Q&A box. So Dr. Kalpana, over to you. Please start.
Yes, Doctor. Thank you, Dr. Nick, for this wonderful lecture. There are some points, some questions which we would like to start with. Before we go there, may I first ask you to just quickly summarize
Your voice is feeble, Dr. Kalpana.
Okay. Now, am I audible? Okay.
Yes.
So there were some questions about the non-IgE and the role of skin prick test in non-IgE mediated reactions.
Okay. Yeah, so remember, non-IgE is we don't understand the mechanism. So it's not IgE mediated. So therefore, skin testing we generally will not do for non-IgE mediated symptoms. So unless they've had those typical symptoms I've talked about in front of or behind the teeth, the reaction occurs within minutes, no longer than sort of 2 hours. We wouldn't normally do any skin tests for non-IgE to confirm a non-IgE mediated allergy.
Right. Yes, Dr. Mahesh, do you have any points to give us first, and then we go ahead with the questions? Any inputs from your side?
Yeah, sure. So thank you, Nick. As always, just to give background that I was trained under Nick as well, and we're part of the Midlands Pediatric Allergy Group. So I learned a lot of things from him. I have been in Dubai for last 1 year, and what I was doing in England and what I'm doing here now, I can see some practice related points and changes. I just want to kind of mention, especially coming to the skin prick test and the panels. So, there we would do just, for example, if somebody is coming in with the milk allergy, peanut allergy, we just test, depending upon, again, going back, history is important. So we'll just test that particular food rather than checking the food panel where we see here sometimes, looking into 40 different food items. And then it really becomes challenging to address parents' anxieties. And actually that gives more questions than the answers. So I would say, by all means, if you want to do the inhalant allergy panel for rhinitis, which is fair enough, but for the food, it's better to go by the history, your decision making. And if you really want to do, just try to send specific IgE for that particular food. Now I'm not sure logistically how easy or difficult, because then we have to think about insurance and lots of things are there. In that case, then better to kind of send to the allergist, and then we can do the skin prick test if necessary. So that's my kind of, so far I have noticed that one. But yeah.
Okay. And if you do suspect an allergy, a food allergy, how is there any age criteria, or you can do it for very young children, the skin prick test we are talking about?
To be honest, we can do even 5 months and from 6 months of age, because what we are doing that as if you look at the LEAP study, just to kind of give early introduction, somebody coming with the eczema, skin is bit all right, then we would do even the peanut skin prick test. And if it's negative, then we'll just tell the parent that go ahead and introduce small amount of peanut butter. But if the reaction is kind of we are not sure, then we'll arrange for the oral food or peanut challenge as well. So we can do from that age group. Having said that, your eczema is well controlled and skin is better as well.
I mean, to be honest, we've done it from 3, because even if you look at the LEAP study, they did it from 3 months onwards. So we skin test even 3-month-olds. Because remember, you're doing a positive control anyway. So you wouldn't, because obviously what people say is, oh, the 3-month-old skin might not react the same way. And that's sort of theoretical, yes. But actually, in practice, because we're doing a positive control, we would know if there was an issue. And, you know, I've done the 3 months old and they have positive control, so we can analyze the rest of the skin test correctly. So there's not really a cutoff per se. Although I think, again, it's one of those myths that, oh, you can't do a skin test in a child under 1. Do you know what I mean? But yes, you absolutely can.
Yeah.
So Dr. Maria Al-Mansouri would like to know, do we need to do food intolerance test in children with family history?
Okay, so now I'm just thinking, does she mean food intolerance test or a allergy test? So there's no food intolerance test, remember, okay? So no, so if you've got a family history of food intolerance, there is no test you can do anyway. Do we need to do a allergy test in a family history of allergy? No, we just say introduce early, and we give that leaflet I showed you from the British Society, because again, there's no evidence that screening is helpful at all. None of the guidelines across US, Australia, or UK recommend screening first. I don't know, Mahesh, if you wanted to add anything to that.
Yeah, I mean, I can get like, where Maria is coming from in terms of the questions, because we do see lots of parents coming in here, like, and they just come in and they don't want to do the like allergy testing, or sometimes they come in with the full, like, A4 size, 2, 3 pages with all the results, and then because they have some history and they can do it. So, but I can get that, but I think as Nick mentioned as well, there is no need to do the test. You just introduce the food, allergenic foods, and then depending upon that, then we can take it forward.
Correct. Okay, a scenario given by Dr. Manoj Chandran, 8-year-old patient with egg allergy, took egg by mistake, had symptoms of throat discomfort.
Kalpana, your voice is interrupting. If a little bit louder.
Okay, doctor. So Dr. Manoj Chandran has sent a scenario. 8-year-old patient with egg allergy, took egg by mistake, had symptoms of throat discomfort, lip swelling, given antihistaminic, presented to us later to ER. Patient is stable, cardiovascular, no wheezing, lip swelling has reduced, but he's feeling tired. Should we give EpiPen in that case?
So probably not, because he's tired rather than drowsy. And normally anaphylaxis will occur within, like I said, a couple of hours of ingestion. But I say within a couple of hours, it's usually within minutes. Maximum I've sort of seen an hour. So if he's had proper treatment, it depends on what antihistamine he had, because remember, and that's the other thing to mention. So for under 2-year-olds, we tend to, well, under 1-year-olds, we tend to use chlorphenamine because that's the licensed one. Once you get above that age, we tend to use cetirizine or loratadine, and that's because they're non-sedating. So the problem with some services still, they give chlorphenamine as their antihistamine. So you treat your mild reaction with that. But remember, chlorphenamine is a sedating antihistamine, so you will feel tired after that. So, and that can sometimes confuse things, absolutely. So what we always say is once you've hit 1 or 2, you should have a non-sedating antihistamine as part of your management plan, not a sedating one. But I think in the absence of any other symptoms and he's just tired, I probably wouldn't give an EpiPen 2 hours later if there's nothing else. Mahesh, would you sort of agree with that?
Yeah, I agree with that. I mean, we can always monitor,
Yeah.
when it comes to ER. But with that particular history, I would just kind of watch for the moment, and it's kind of 2 hours as well, so unlikely anaphylaxis.
Kalpana, because Dr. Diyari is not there, Dr. Kalpana, to select a question, I'll ask one question. Dr. Nick, we had a lot of discussion, window period. Some said you start from the 4 months. If you start the food causing allergy, the child will not be allergic. There was a lot of controversy. Many people refuse this. What is the latest, I mean, evidence on this? If we start the food which are causing allergy earlier, will it prevent? What is the latest? You're the authority on this, please.
The latest is yes, it does. So I'm not sure what the controversy was. Certainly with LEAP, there was no controversy. The peanut, absolutely robust evidence that early peanut introduction prevents peanut allergy. So that's easy. The EAT study was the other one. I think the problem, like I say, with the EAT study was it was a population-based intervention. And it's quite hard to introduce the foods they wanted them to introduce in the order they wanted them introduced in, with the level that they wanted to do. So it was that lack of being able to do it correctly. But when they did the per protocol analysis, if you followed their protocol exactly, then you did reduce your evidence of your incidence of food allergy. So there's no doubt, I think, that early allergen introduction works, but it's difficult to do. That's the problem. So if you look at our BDA and BSACI guidelines, it gives you clear sort of ideas of how to do it. But yes, I think the main issue is the science behind it is robust, but it's a practical application that's difficult.
Thank you. Thank you.
Sorry, I will just pick up one question from the question. I know there are lots of questions, and
That's
sorry,
fine. Yeah, go on, Mahesh, you answer it.
So I can see that from Fortune mention about the worried about child's growth when given steroids for longer period, and really a good question. And when we do see lots of parents coming in with the eczema, and the minute we mention about using the steroid creams, they go a bit on the defensive. I think I would say that, as Nick was mentioning, we need to make sure that we maintain the skin very well to avoid the future allergies, because food entering to the gut and through the dry inflamed skin is completely different thing. So if we give a time to the parents and explain the benefit and risk and benefit in terms of using the steroids, and the importance of healthy skin, most of the parents in my practice I have noticed that they will agree to it. Now, what I say is, okay, I want to see them again probably in 2 weeks, 3 weeks. I know some people say, well, there is no any fixed timeline, but it's just more kind of reassurance point of view to the parents that, okay, somebody is monitoring the skin. And if we explain them different strengths of the steroids, like mild, moderate, and severe, most of them, they actually comply with it. And then obviously you need to manage the height and weight and growth along with when you're using the steroid as well. So just wanted to kind of clarify that question. Thank
Right. There's a question from S. Kumar about an 18-month-old previously tolerating kiwi fruit, recently had hives and lip swelling soon after eating. How do you explain that?
Yeah, so the problem with allergies, anybody can become allergic to anything at any time. So we have new diagnosis of allergy to peanut in adults who've eaten it all their lives. And that's the problem, isn't it? No one really understands how we flip from being tolerant to allergic. Obviously, there's a lot of sort of data now on epigenetics, gene and environmental interactions. So no one really understands it, because if we understood that part of it, we'll be able to stop or treat allergy and cure it. But yeah, so I think there is no explanation at the moment, but what we have to be mindful of is that just because someone's tolerated a food forever and then they suddenly start reacting to it, we shouldn't dismiss it because they could have developed a new allergy.
Yeah.
Couple of questions on allergic rhinitis. I think somebody's asking a personal question about a 4-year-old kid who always has a runny nose, repeatedly been taken to hospital. Doctors have said he has allergy. They've given medication, including injections, but nothing has helped. What should they do next? So would you advise any allergy testing in such a case?
Mahesh, do you want to take that one?
Yeah. I mean, again, I mean, with that history going forward, I would like to see, have they used the like Nasonex or any steroid sprays, and how is there improvement in the symptoms or not. Again, allergic rhinitis, I mean, it can be non-allergic or allergic. But yeah, I mean, to begin with, we can do the like either skin prick testing, or we can do the inhalant allergy panel first. And then depending upon that, we can make the next plan. So if they haven't done any tests, I think the first step is we can do the test, and then we can decide.
And the other thing just to add is to say that in a lot of these sort of aged children, they've often started nursery or they've been in nursery, and they get recurrent viral rhinitis. Because remember, the average child gets one viral infection a month. So I remember your viral rhinitis can last for 4 to 6 weeks. So they have viral rhinitis, they're getting over it, they get another one, and then it carries on. So you think they've got consistent runny nose. So it's trying to, again, it's your history that'll tell you. So obviously, if you've started nursery, I had a child today who started nursery, has had a consistently runny nose since, but actually is fine during the summer months. So, you know, I could say clearly you haven't got an allergy, you've got viral rhinitis, you know. Obviously, if you've got a child who's being fine and suddenly starts getting recurrent rhinitis as the weather improves and the summer months appear, then you're more likely to go down the whole allergy testing route as well. But yes, you know, that's somebody we would think about testing to all the aero allergens to make sure.
May I interrupt one question and comment? Professor Nick, this is a frequently asked question about the nasal steroid, how long to be used. No, the method you said, I described Jimsman method.
Yes, correct.
Jimsman
Well
method.
done. Yes.
So
Yes, good.
that
Well
you
done.
see it directly
Yes.
towards the nose. Before that, mildly blow the nose, but after putting, no sniffing should be done.
Good.
I mean,
Yeah.
this
Perfect.
instruction.
Perfect. I call it the Marvel because I look after kids. I say I do Marvel superheroes. I go it's a Marvel superhero method. But you obviously you look after adults, so you do the 007 method. That's fine.
How long you usually recommend continuous use?
So again, yeah, so certainly, so obviously if you've got it just during the summer months, I'd just say use it over the summer period. If you've got house dust mite allergy, that's difficult because obviously house dust mite allergy is perennial. So what I normally say is use it for 6 months, then try and reduce and stop to see if you actually still need it. Obviously, if symptoms come back, you restart it. So you can use it consistently because if you use the new ones, like I said, you don't really get much bioabsorption. So you can use it for prolonged periods, but you should always come off it every 6 months to see if you still need it. That's the key thing, not to just continue it for 2 years on a daily basis.
Yeah.
Thank you.
And just to add, like, you know, the method is so important. Whenever I come in the class, just first thing I ask them, how are you using the nasal spray? You know, believe me, majority of the time they might be using it in like, you know, just putting like this, sniffing the one we use like saline spray and all those things. So yeah, very important.
So there's a question about your opinion about using hypoallergenic formulae to prevent eczema.
So no good evidence for that at all, unfortunately. They've done lots of studies. Some of the studies that said there was a difference, the methodological problems with those. So at the moment, unfortunately, there is no evidence to recommend hypoallergenic formula to prevent eczema.
Yeah.
I think connected one for cow's milk allergy, there was a question about how long would you keep the child on amino acid formula.
Mahesh, do you want to take that one?
Yeah, I mean, like in England or Leicester, we used to kind of like, you know, depending upon the follow-up, how the symptoms are, if child really needs it, you know, up to 1 year, we were saying there, and then maybe like, you know, after that, try to introduce maybe partially hydrolyze, again, depending upon the history and symptoms. But we don't recommend like, you know, going beyond 1 year continuously using I mean, because that has cost impact and lots of things as well. How do you feel, Nick, about it?
Yes, I think, I mean, you know, if we talk about just the diagnostic part of it, that's right. Yeah. So diagnostic maybe is 4 weeks and then you try the other formula to see. Once you're established, absolutely. So we'd leave you on it. Again, it depends on what age you get put on it as well. If it's for non-IgE, again, we would normally say continue it. We start baked milk introduction at 10 months old to try and get them over their sort of allergy. Normally that means introducing normal milk back into the diet when they're about 14 months old or so. So yeah, so usually 6 to 12 months is fine. For IgE mediated, obviously they will continue until, again, mainly over to once they're 1 year old, because after they're 1 year old, there's lots of other options.
Other options are there.
Yeah, so you know, because remember after 1 we can use normal blue milk, but obviously they can't because they're allergic. But then we'd use oat milk or soy
Oat milk
milk.
is there,
Yeah.
And we have that available in UAE as well, like in Dubai, in
Yeah.
supermarket, oat milk is available there. So
Yeah, so that would be fine.
I would like to ask one question. Professor Nick, you mentioned about sedating antihistamines. Nowadays, especially in the younger infants below 1 year, the recommendation is not to give the first generation because of the side effects in this group. If you want to start, how long you will give? I mean, how frequently you recommend?
So under one, I don't really use it unless there's a reaction. So remember, we'd only be giving an antihistamine in the case of a mild allergic reaction, which really shouldn't happen because the parent is controlling what goes in their mouth. So I don't really recommend daily antihistamine in children under 1 at all, so they don't get it. I would only use it for an immediate IgE mediated reaction. The only other time I use it, the only other time I suppose if I'm thinking about it that I might use it, I might use a sedating antihistamine. So some of the older ones, you're right, the first generation they say you tend not to use, but it's that whole risk benefit thing coming into it, isn't it? So children who've got very severe eczema, who can't sleep because you're scratching all the time, families at the end of their tether, I will often use either hydroxyzine or alamemazine for 7 to 14 days for the acute flare to knock them out so they can sleep, not scratch, give their skin a chance to heal. Because I think the benefit in that scenario outweighs any potential risk. But my general mantra is not to use them on a daily basis.
Do you recommend to do prick test for specific IgE in cow's milk allergy? If yes, at what age?
Then Mahesh, did you want to take that?
Yeah, I mean, again, if it's like history is suggestive of immediate IgE mediated reaction, then we can do the skin prick test. And as Nick mentioned, as young as 3 months of age, we can do it. But it has to be like, kind of immediate cow's milk protein allergy. We should be thinking about that. If it's delayed or non-IgE mediated, then doing the skin prick test wouldn't be helpful.
As far as severe reactions are concerned, the reports that we read about adolescents, trying some foods with nuts, especially. Why is that so severe? Is there any truth to the nut allergy being at the higher end of the spectrum?
So why are reactions severe to some foods and not others? I suppose we don't really understand why that is. I mean, some foods are, I suppose the proteins are more allergenic. And again, if you think about it, so milk and egg, you need about 500 milligrams of protein before you provoke a reaction. Whereas something like nut, you only need 5 milligrams, not 500, and you get objective symptoms at 5 nanograms, so tiny amounts. So you're more likely to ingest a higher volume and therefore provoke more mast cells to activate. So that's one of the reasons. The other thing you have to remember about sort of reactions, they are related. The reason your skin test or your specific IgE can't predict your severity of reaction is because that depends on cofactors. So what I always sort of, how I describe it is on one day you could eat a quarter of a peanut and get lip swelling and hives. On another day, you've not slept all night, you've got a viral illness, you miss your breakfast, you run for the bus, you have a fizzy drink, you get exactly the same amount of peanut and you have anaphylaxis. And that's because all of those are cofactors that we know increase the risk of a chance of a more severe reaction. So I think the cofactor is the reason that we can't predict from tests what your reaction is going to be.
I think particularly for the wheat, like, probably Nick might agree with the wheat, with the cofactors, exercise and other factors. So your reaction can become severe.
Yeah, definitely.
May I ask one question? Oh, Tatkarna, please go after that, I'll ask.
No, I was just going to ask Dr. Guru's question. Is there any scenario where acute anaphylaxis would not be responding to 2 doses of EpiPen?
Yes, very rarely. There is scenarios where it won't. And that's what we call refractory anaphylaxis. So those are the ones that will need adrenaline infusions, end up on intensive care units. They are rare overall, and most kids will respond to 1 or 2 doses. And in fact, most kids respond to 1 dose. So the likelihood of needing a second dose is quite small, actually. If you look at the data, I think Cambridge did a lot of the work on this, and they realized that even kids who got a second dose often didn't need it and they were giving it just in case. But yes, so we do have something called refractory anaphylaxis where 2 doses won't work, but they will need ITU and adrenaline infusions. And if until that time comes, let's say you're stuck in an ED waiting, you would just keep giving adrenaline IM every 10 minutes until you've got more definitive access and treatment.
Okay.
And I would like to ask one question, Professor Nick, about the use of topical steroids, because parents are very much concerned, be it every day or alternate use. How long is maximum you are using?
So, like I said, I tend to. So, what I will always do is, I think the mistake a lot of people make and why parents don't think steroids work is you'll get a child with really severe, I saw one today, really severe eczema, and people are using 1% hydrocortisone, which is not going to do anything on really severe eczema. So, you need to go in at the level. So, obviously, if it's severe, you need to go at the high level and then you work your way down. And then what I normally tell parents is every time it flares up, you're going with the right level of steroid. So if it's a medium flare, you're going with your medium strength steroid, mild strength steroid, and then stop. If it then flares up again, if it's a mild flare, just use your mild strength steroid and then stop. And you can continue doing that. If you're finding they're doing it, so I normally say if you've done that 3 times, so if that's happened 3, every time you stop, you've had to restart it, then there's 2 options after that. So option 1 is you go to twice weekly steroid. So you use a potent or medium strength steroid twice a week. And that often helps parents to not worry so much about side effects. And you can do that for a couple of months easily. So we normally say Saturday and Sunday just because it's easy to remember because you're not at work. The other option is to go on to a neurocalcin inhibitor. So in a sort of under 2-year-old, I use Elidel, pimecrolimus. In over 2-year-old, I'd use tacrolimus. And as soon as your 3rd flare is treated, you finish your steroid, you go straight onto your neurocalcin inhibitor. And again, you use that for 8 weeks daily without any issues. Then I say go to alternate days and then stop and see. But you know, I think ultimately what I tell parents is poorly controlled eczema has just as much of an impact on your skin as incorrect use of steroid. So I give them an eczema management plan. They know exactly what steroid to use when to step up, when to step down. And generally, if you give them that, they manage it much better. The other thing I would sort of say, the other website I'm recommending to all of them now is something called Eczema Care Online. If you Google it, Eczema Care Online, there's some evidence that people who educate themselves on that website and use their tips on that website, they gain better eczema control. So again, maybe that's something else you could recommend to your patients, because again, that will reassure them about what you're doing is correct and is fine.
There is one more thing generally I mentioned, like how much steroid they're using. So like, you know, if you like take a 1 fingertip unit, that will kind of cover your palm. So just kind of general guide, because sometimes if we tell them to use it, they will just use like a very small amount, and the tube is same like that we prescribed 2-3 weeks ago.
Yeah, in extension to that, there's a question about the use of systemic steroids in eczema. Do you use
No, systemic steroids we don't really use at all, and purely because it'll work brilliantly, but you can't continue to use high dose steroids in children. So what we would then do, if we feel, sometimes very rarely I'll use, if it's particularly bad, I'll give them a 5-day course of 1 milligram per kilogram, but I'll be referring to the dermatologist because then they'll probably need systemic immunosuppression with either cyclosporine or azathioprine. But I would then let the dermatologist decide on that. I don't know, Mahesh, if you do anything different.
Yeah, no, I mean, if we go to that stage, I will just send it to dermatologist as well.
Okay, and the use of crisaborole in atopic dermatitis?
So we don't use it, I have to say. I don't know if you've used it much. We don't really use many monoclonals. The only monoclonals we use is dupilumab. So that's the one we use. But again, I very rarely have had to use it. I'm trying to think the last time I even used it. I mean, generally the dermatologist will use that more often than the allergist. So I don't tend to use it very often. Dermatologists may use it a bit more. But again, if we get the control right with the right creams and right zones, very few actually need to go to that level, is what I find.
Yeah, I agree.
And for children with eczema with very large areas of skin involved, all these topical medications, would they be okay to use?
Again, if you're using the finger, again, Mahesh, you talk about finger. Why don't you answer this one?
Yeah, no, I think, I mean, again, like going back to the use of the steroids and explaining to the parents uh, risk and benefits of using and not using it in the future. And as long as we are monitoring their height and weight and overall growth, uh, they are safe. Obviously, we'll tell them like, thinning of skin and those things will be there. But I think finding the balance of using the steroids, and it's more, again, comes to the explanation to the parents. I think that's what it ultimately comes to. But it's safe to use even if it's like whole body is covered. Kind of over the face, mild steroids on the body. You can go to moderate to severe, and then regularly monitoring them in the clinic. I think that would be the best way of management.
Yeah.
Anything you want to add, Nick?
Yeah, no, I'd agree. Again, I don't know. I've obviously had a clinic of patients that we're talking about today. So I had a 5-month-old with, horrendous eczema all over the body. And I've gone straight in with a potent strength for 2 weeks because, this child it's usually his clothes off. All he was doing was just constantly scratching this, and they did that all night. He's not sleeping. We've got to get it under control. That's the only way to do it. So, yeah, I've gone straight in with this potent, and then they've got a step down plan like we've just discussed. Our step down, our plans all have the fingertip units, so they understand how to use all of that. And the Eczema Care Online also tells you how to do that correctly. So again, I think if you're using it, the evidence is just if you use it correctly, as we tell you to, there isn't any short or long-term sort of side effects.
Yeah.
Also, Nick, what about the use of emollients before steroids? Because I have seen parents applying on the dry skin. Actually, emollient should be applied just after bath when the skin is wet to keep the moisturizer. They say 15 minutes after application of moisturizer, you apply other creams. How often, I mean, what is your system of practicing in these cases?
Yeah. So again, if you look, there's two complete opposite ends. So some people say emollient first, wait sort of half an hour, and then put the steroid on. The idea being you've softened up the skin, you make it a bit easier for the steroid to be absorbed and do its effect. And then there's a complete opposite on the other side where they say put the steroid on first to get it right on the inflamed skin, wait 10, 15 minutes, and then put the emollient on to lock it in. Okay. So again, there's no real evidence. So I tend to do the steroid first, wait 15 minutes, and then put the emollient on top and lock the sort of steroid in to make it work. And I talked to our dermatologist about it because we've got pediatric dermatologist. So what do you do? He said, I do the other way, but actually your way is fine. So, so there's no, I think it's whatever you feel.
Yeah.
To me, it's whatever scientifically makes sense in your head. Is what I say you do.
Because they say moisturizer to be applied when the skin is moist in order to maintain that moisture.
Yeah. So obviously you will put it on straight after a bath, but then you need to maintain that, like I said, at least 4 times a day. So you constantly put it on. So the idea is you're absolutely right not to let the skin dry out. And what I always tell parents is in the ideal world, you'll be putting on this cream every hour, but that's not possible when you're working, when you've got to sleep, so you've got to get the sort of balance of, putting on every hour in the ideal world, but putting on enough so that your skin doesn't dry out. So that's why I say 4 times a day is your absolute minimum. 6, 7, 8 times a day. If you can get it on, even better. So it's that balance between what's practical and what's actually the best practice.
The other problem, I mean, how we say that how much cream amount you are using in a week. For example, 500 grams you are using in 1 or 2 weeks.
Yeah.
But here, with the insurances, if we put the 500 gram full tub, they might not cover it. And then we have to go to 100 and 200. And then sometimes we don't know how much cream the patients are using it as well. So that has been the issue I have noticed.
Yeah.
Because you are giving them the cream and they might be using it for 1 month, so they might not be using adequate. So I always say, go back to the basic, use your moisturizing cream, emollient frequently and generously so that you have to, your use of steroid will go down.
There's a question about present recommendation regarding duration of montelukast therapy, keeping in mind its effect on children's behavior. First of
Yeah.
all, have you noticed anything in your practice? And secondly, what's the current recommendation?
Yeah. So I very rarely will use Montelukast, to be honest. I mean, I used to use it before, obviously, the recommendations and the sort of more robust. I suppose that worry's always been there, hasn't it, for many years about that effect on sleep and behavior and stuff. But I suppose we have a lot more robust sort of data now saying there's a problem. So when I used to use it anyway, I didn't really find it added very much. Very rarely did I have a child who had horrendous rhinitis. I'd done everything else, added Montelukast, and suddenly they miraculously got better. So I didn't feel it worked particularly well for that. So I really don't use it now. If I did use it, obviously I'd always warn the parents, any change in behavior, sleep disturbance, you just stop it. Don't continue no matter how long you've used it for. And I think what I would probably do is if I did use it again, I would give a maximum of 3 months. Because obviously if it's not, we always told us if it's not worked by 6 weeks, it's not going to work. So I would give it a maximum of 3 months. If it's not worked after that, I would stop it. If it did work, I will probably still say at the end of 6 months, let's tile it off and see, because it might have been enough just to, get you over the sort of threshold of treatment control. When we stop it, it might, you might not need it now that it's under control, everything else will work. So I don't think I would personally, I don't use it at all now, but if I did, I'd probably use it for 3 months and only if it worked.
I would like to add on. Well, FDA said for allergic rhinitis, it should not be used alone. And
Correct.
just
no, it's always an add-on.
yeah, historically, Montelukast was developed in Montreal University, Canada. That is why it is called Montelukast, Mont from the Montreal University, leukotrienes.
Yeah. I should have said thank you, Dr. Sarab, for your wonderful historical review of allergy. I forgot to say. I was worried about my time in my talk, so I thought, but it was a wonderful, and I think I will very be happy to get those slides shared with me, because I'll use it at some point to share the history of allergy. It was brilliant. Thank you.
Thank you. So nice of you. Thank you.
Yeah. So there's another question, like if there is a history of cow's milk allergy in a first child, would you straight away use completely hydrolyzed formula in the next baby?
Did you want to take that, Mahesh?
Yeah, not really. I wouldn't. I mean, again, it's going back to the same thing. If there is a family history of not only cow's milk allergy, any food allergy, I wouldn't advise to go to hydrolyzed formula straight away. Again, going back to the basics, breastfeeding, just continue as you would do as in any other normal situation.
One point I would like to add, Professor Nick, FDA in 2021, a group of FDA people, they did a study, they compared Montelukast with steroid, and they found no side effects, because psychological side effect was not there. I have that paper, although CDC give the box contraindication, but the same people from the CDC, they did the study and they said there is no psychological.
Yeah.
And we haven't seen. I don't know how other pediatricians.
I agree.
That
yeah. So sorry, Dr. Sarab, I agree with you. So when I did use it, the reason I don't use it is because it's not effective, not because I saw particularly any side effects from it. So the only side effect I ever really saw was sleep disturbances in the younger kids, but not often. I always warned parents about it just so they knew, but I didn't really say, and obviously we used it in asthma a lot more in the past, but I didn't really see any issues with it. So I don't really not use it because I saw side effects myself. I just didn't find it very effective. I suppose that now, because of all the data, we have to be, we certainly had alerts in the UK saying really we should only use it if we absolutely have to. So we have the MHRA alerts in the UK. So I think for that reason, we're all of us in the UK a bit more wary. But I agree with you. It was a bit like the whole domperidone, isn't it? We weren't allowed to use domperidone because of the cardiac toxicity and all of this. And yet I'd used it for like 20 years and never had a problem with it. But now there's an alert so you can't use it for reflux. So everybody stopped using it.
Right.
Nick, I just want to ask something. Like there was a question about from Ram Niwas, the omalizumab in prevention of food allergies, and FDA has approved. So in UK, any discussion about that at the moment, or with the NICE guidelines and everything coming up? Or
There's nothing at the moment that I'm aware of to say that we are using it for prevention. It's obviously potentially can be used to help with making immunotherapy better. So so obviously sort of having a better response to immunotherapy, but otherwise the only real indication that we have for children is obviously chronic urticaria. We use it for and we use it for severe persistent asthma.
Yeah.
Obviously you probably know in adults they use it for allergic rhinitis with polyps only. I don't know, that's the specific thing it's for, but the off license we can use it for immunotherapy support, for food immunotherapy, but otherwise no, there's not. We only use it, I have to say. So obviously we have our respiratory team who use it for the asthma. I don't use it for asthma, but that's
Yeah.
they do it. We'd only really use it in our practice for resistant chronic spontaneous urticaria at the moment.
Yeah. Okay.
I think one more scenario, 14-year-old child with no past history of any allergies, develops urticaria rashes on and off, relieved with antihistamines, not usually related to any food exposure. What should be the approach in such a case?
Yeah. Mesh, do you take it or do you want me to? I don't mind.
Yeah, I mean, like, I think the looks kind of like, urticaria. Again, going back to the history, how long is the rash has been? Are we talking about the chronic urticaria here? Or generally what we say, like, sometimes parents or child might have the pictures of the rashes. Again, going back to the history, has any specific trigger found? If there is no specific trigger, then we are looking into the chronic idiopathic urticaria. And then how many times, like we call urticaria diary as well. Initially, we would say that, okay, if you're responding to antihistamines, which antihistamines you are using? Now, child here is 14 years old, so over 12 years of age, fexofenadine, least, I would say, sedative antihistamine. Continue to use that, keep urticaria diary. If it's happening more frequently, then we can assess again. And then there are certain investigations as a chronic urticaria we can do, looking into autoimmune conditions. So I think it's the kind of graded approach, looking them in the clinic or seeing them frequently and regularly, what is happening, and looking at the urticaria diary. That's how I would go, rather than going into doing the allergy panels or trying to find out the problem. I would go by the history first.
Yeah.
Anything you want to add?
No, I'd agree. Yeah, that sounds like they've got chronic spontaneous urticaria. So remember, you can have a food allergy and have chronic spontaneous urticaria going on. So it's important. Again, like I say, in allergy, it's all about the history. It's like a detective story. You've got a something that's happened. So instead of a murder, you've got a reaction. Then you've got a whole load of culprits. So you've got to work your way by the process of elimination what those culprits are. So I always think of it as like a detective story, an Agatha Christie or James Bond, or whatever you want to go down. So if you've got a child who's having spontaneous urticaria, there's no obvious ingestion, there's nothing else in the environment, then I'd probably say that sounds like chronic spontaneous urticaria, and I'd do exactly the same as you. We tend to now, in the UK certainly, there's a whole list of tests you can do for chronic spontaneous urticaria, but if the history is consistent, the child is otherwise well with no other symptoms that are worrying, then we'd just start the treatment. We do that for 6 months, come off the treatment, and that in most cases that will resolve, because most of this chronic spontaneous urticaria will burn itself out fairly quickly. Some is a bit more chronic, as we know, but some is burn it out. If after 6 months when they come off the antihistamine, the symptoms recur, then we'd say, okay, go back on and we'll do the test just to make sure there's nothing else going on. But very rarely have I found an abnormality on a blood test, which I didn't suspect already. Do you know what I mean? So the history and examination usually tells me, actually, I think you might have got celiac, or I think you've got thyroid. But if I don't have anything else that worries me, I'm trying to think if I've ever found an abnormal. I can't think of I've ever found an abnormal test. And I think that's what the evidence says as well.
Yeah. Well, there is a mention at some places that in 50% of cases, you might never know the cause.
Yeah.
Isn't it?
Yeah.
So,
there's a lot of what we call acute urticaria, idiopathic urticaria, which comes and goes for 6 weeks and then it stops. And
Yeah.
most of the time that's felt to be related to probable underlying viral infection, and that's just disrupted the immune balance for a period. That's why we don't diagnose chronic spontaneous urticaria until after 6 weeks, because there's lots of acute urticaria which comes and goes for 6 weeks and then just stops. And we think that's probably going to be related to some underlying infective episode.
Right. I think we're done with these questions. I just wanted to touch upon multiple food allergies and drug allergy. These two. Yeah. So, Dr. Nick, you can tell us something about your cases with
Okay.
multiple food allergies.
Yeah, so I mean, multiple food allergies are always very difficult, I think. And I think the key thing really for multiple food allergies is, I suppose, a couple of things really. One, the most important thing is a dietitian for those, making sure that they've got a diet that's complete despite the multiple food restrictions. So I think those ones definitely dietitian input, definitely regular monitoring of the height and weight, and making sure that they're nutritionally complete. And for those, we would do sort of fairly regular testing because we want them to grow. We want to pick up anything growing out of quickly. So they'll have 6 monthly to yearly reviews, retesting. And as soon as something goes negative, we'll say get it back in quickly, to make sure that you're not being restricted unnecessarily. As they get older, if they're not growing out of it, then obviously now we have the option of desensitization, particularly to milk, egg, nuts. There is that option there. But otherwise, there's not much else you can do until they've grown out of it themselves. It often becomes difficult with vegetarian families who are allergic to nuts and the multiple legumes. So they're the ones that we obviously have to then really monitor with diet and growth. But I don't know if anything else, Mahesh, you would do with those. So I'll get you to come to that in a minute. And then for the drug allergy, yeah. So yeah, there's a big drive at the moment in the UK to delabel penicillin allergy, because a majority of penicillin allergy in children is non-existent. So 95% of children who think they've got where they think they've got penicillin allergy actually haven't. And it's, again, there's 3 ways of doing that. So we can either completely discount it on history. So again, what I'd do is I'd get you to look at there's a BSACI penicillin delabeling guideline. So that's good. It gives you a green, amber, and red category. If it's green, you don't need to do any tests. You can delabel basically on the history. So a typical would be, a child who's had a viral illness. They go to the GP, they get penicillin. They have 5 doses, and then 3 hours after the final dose, they get a rash. But they're otherwise completely fine. So if it's not urticaria, there's no other symptoms, they've had multiple doses, it's way beyond the IG-mediated reaction component time, I would say there and then that you haven't got penicillin allergy, delabel you. If there's sort of a itchy rash, it's within a couple of hours of the doses, then we may do some testing. But actually, what the sort of drive is really now is because the testing isn't that accurate for penicillin allergy. So only about 40% of kids with true penicillin allergy will actually have a positive test. So what we now do is just go direct provocation challenge. So we go straight to just giving them a dose. And actually, if I'm happy that I think this is still unlikely, I will give them a dose in the clinic on the same day rather than do any tests. I'd just say, right, give a dose, sit in the waiting room for an hour. And if they're fine, we've delabeled you there and then. Obviously, if you've got a very good history, you took 1 dose, you've got lip swelling, eye swelling, hives, then I'd say you're not going to have any delabeling in the clinic. If you've had a very severe delay type reaction, so DRESS, obviously, Stephen Johnson's, if there's anything like that, again, we probably wouldn't then do anything with that because we don't want to provoke. So with the IG-mediated potential one, I will then do testing. If that testing comes up positive, I'll say that's fine, you are allergic. If the testing's come up negative, then we might still do a direct provocation challenge, but then we'll do a stepwise challenge rather than just give a dose in one go and then wait an hour. Then we'll do a graded challenge. For the ones that we think have led to severe delay type reaction, we wouldn't, and just tell them to avoid. So I don't know, Mesh, if either of those two.
Yeah, I mean, I will just continue probably with because we're on drug allergies. So, as you mentioned, depending upon what kind of reaction they have, sometimes they have, amoxicillin or augmentin, and then day 3, day 4, they have some rash, and that could be part of either illness itself, and very kind of low risk thing. Then again, as I said, in the clinic, I will just give the augmentin dose kind of challenge kind of thing. But if the history is okay, immediate reaction, not so severe, but in those cases, then I will bring them for the oral challenge. Again, here the difficulty is bringing them for the challenge is again coming back to the insurance and all those kind of things. Then you have to get approval and all those things. But I have done some oral augmentin and brufen challenges here, and so far, we have, I managed to kind of delabel them. Nobody has reacted, and kind of low risk as well. So that's the one part actually I'm focusing on here as well. And for the multiple food allergies, again, it's very challenging, and sometimes getting dietitian is tricky, who is kind of expert in pediatric parts, because that's kind of multidisciplinary approach and very important to have dietitian opinion. But I'll just go like one step at a time, one food at a time, because there's so many foods, and then parents sometimes get very overwhelmed. So I'll just take one food or two foods, check for skin test. Okay, depending upon reaction, how is the reaction, introduce that particular food, again, see them in the clinic. So that step-by-step approach, I'll go with that.
Right. Actually, many children are deprived of antibiotic because of, as you mentioned, they get fever on third day, like let us say rozola. They get a rash, they attribute it to the antibiotic, and they just write in a history. Once written in the history means whole
That's
life.
it. That's it.
This is one problem. Second, here when we write any antibiotic parenteral, invariably test is done. I mean, what is the practice in UK? I mean, is it the right way we are doing? As you say, 94% of cases are not allergic to penicillin. The way it should be done, it is not done.
Yeah.
If it is done in the way described, then. And second thing, after this, about the use of calamine in this urticaria, because some dermatologists, they are going against that because it makes the skin dry and they don't recommend. So first about antibiotic, please.
So yeah, so what was, sorry, I missed it. What was the question for the antibiotic?
Because once rash comes, they deprive a parenteral antibiotic, invariably they test for all. Is there any exception, or what is the practice in UK?
So you mean once they've got one, they test for all the antibiotics? Yeah, no, we don't test. Again, we wouldn't test for all the antibiotics. If they're reacted to penicillin, we just test for the penicillin. Actually, if I'm being honest, I'll test for amoxicillin because that's the one we give generally. So I test for amoxicillin. If that's clear, I'll give a dose of amoxicillin and say that's it. You'll be fine now with the penicillins, and generally that's fine. It'd be very unusual. Again, I have kids who come and they've reacted to erythromycin, they've reacted to clarithromycin, they've reacted to augmentin, and I've yet to see a multiply antibiotic allergic child. A lot of the time when we start talking about the history, they say they're reacting, but they've had diarrhea with erythromycin. So they say that's an analogy, but obviously it's not. That's a side effect. So then we can say, right, you're not allergic to erythromycin. So we can delabel some of those just on history, and then the rest we'll do just with a direct provocation test. But you're right, we do not test. Just as in with food, we do not test multiple. If you're reacted to amoxicillin, I'll trust you to amoxicillin. We might do penicillin, just that's the only other one we might do, and then we'll delabel you based on the information we get from that. And now I've completely forgotten your second question.
Calamine, use of calamine lotion in
calamine lotion. Yeah, no, we don't use it. We don't. I think it's good for the it's good for something for the parent to do. They can put dots of calamine lotion on things, but there's no evidence it actually does anything at all. So it's more that the parent feels they're doing something rather than it's medically effective. Sorry, Mahesh, you were about to give me something.
Sorry, I think I'm going back to the question. I'm not sure. You really got what Dr. Saurav wanted to say.
Sorry.
Specifically, here what happens is before giving every IV antibiotic, you give the test dose.
Oh, right. Oh, no, we don't do that. No.
So that's what I was,
Sorry. No, we don't give any test doses. Obviously, if you are allergic to an antibiotic and we have to give you that antibiotic, then we might do a rush desensitization. So we give you a tiny dose, and then over a couple of hours, we'll give you the full dose. But that desensitization only lasts for the course of your antibiotic. But again, we don't really do that in children because we have really good alternatives anyway. And the only thing that we know that can only be treated with penicillin is syphilis in pregnant women, which is not in my area, so I don't worry about it.
Okay. So, one last question from Dr. Guru: role of tryptase in a suspicion of anaphylaxis.
Yeah, so I think tryptase is really good. So you obviously take it as quickly as you can when the reactions occurred, and then you want to sort of ideally take it 24 hours later, so you get one at the time and one at baseline. So it's very good for venom drug-related anaphylaxis. It's not so good for food-related anaphylaxis. So we always sort of recommend it for if you suspect an anesthetic perioperative allergy reaction, then we say you must do a tryptase because it'd be really useful. If we suspect venom anaphylaxis, you can do a tryptase. We do say do it in food. If it's positive, it's helpful. If it's negative, it's not, because there's a lot of good evidence that actually food-related anaphylaxis, tryptase doesn't have the same sort of escalation effect. But yeah, but definitely for drug, definitely for venom.
So, Dr. Saraf, you have any more questions? Or else we'll
It's
ask.
midnight in India. Now in India it's 12:30. Still they are following us. I think they will stay till morning if we continue.
So then in that case, I would request both the experts to give their final comments, and then we would close.
Okay. Well, like I said, for me, I think my key takeaways were there really. So, you know, IgE needs testing just to make sure you've identified the right allergen. Non-IgE, don't do any tests, do the exclusion reintroduction. If you're giving any treatment like nasal sprays we talked about, auto-injectors, make sure that people have been trained on how to do it. And allergic rhinitis, again, train them out to use it, make sure you escalate correctly, and consider immunotherapy because it's very effective.
Thank you. Dr.
Yeah.
Mahesh?
Yeah, I mean, Nick has covered most of the things. I would say that in terms of if you're seeing the eczema, try to avoid the food panels because might create more, problems than the answers. And in terms of drug allergy, yeah, I mean, see the opportunity, like, if you can do the delabeling. If it's safe to do, do it in the clinic, or if you feel that, okay, he might be the potential candidate, then, you can refer to the allergist, and happy to have a look as well, because it has impact in the future, because that label carries you in the adulthood. And, you can imagine in the adult stage, going to emergency, in emergency situation, you are allergic, and then window of antibiotics really goes down. And then you are giving higher antibiotics and then antibiotic resistance. So it has a big impact. So that would be the message. And thank you, Nick, so much. Other thing I wanted to say that Nick does the Palforzia in Birmingham, and then in UK we don't have Palforzia yet for the peanut immunotherapy. So any patients, and they're willing to go to Birmingham, Nick is the guy.
Thank you. Okay, Dr. Saraf.
So I would like to thank Professor Nick for the excellent presentation and discussion. A lot of doubts cleared. Really, we will have, I think, in future more sessions. I would like to thank Dr. Mahesh for taking part in the discussion, Dr.
Thank you.
Kalpana, Dr. Tawfiq for sponsoring, and our viewers from all over the world. I think more than 500, now exact number, Dr. Tawfiq will give us. Once again, I would like to thank all. I'm sure in the near future we'll have another session on allergies in children. Thank you very much and good night.
Good night.
Thank you.
Thank you.
Good night, everyone.
Thank you. Good night.
Thanks.
Okay.
Bye-bye. Bye-bye.
Bye.